Good afternoon. The organizers of your conference asked to speak on the topic of insight from new blood group systems and why it might be worthwhile to continue studying blood group systems in a field that started 120 years ago. And I try to give you such insight today. I have been to your beautiful country in Kasab, next to the street of Hormuz, and I apologize for not being able to attend today in person because of other travel obligations this fall. This slide shows my disclaimer. I have no conflicts of interest, and I like to point out that particularly the new blood group systems may need special consideration for regulatory aspects when you try to test these antigens with systems. This can also be an opportunity for studying such topics in your countries because you have these special considerations differing between various countries. I just want to make sure that you follow those regulations that apply to your region. Now, the objectives of my presentation are outlined here. I will address what are the recent developments in blood group antigens. How are these antigens summarized systematically in a field that bears the name blood group systems? So what are the definitions and the molecular structures? There is a particular opportunity currently in your huge region with the large population in Asia. That's called the Asian type DEAL, and I will present a little bit on that. And then conclude with the question, what can transfusion medicine contribute from a patient perspective? What is the impact on practical care and safety? And I make a point that we are able to establish large databases for biologic variability and pathophysiology. That's an opportunity for the field in transfusion medicine, particularly in Asia and worldwide. Now, a blood group system is defined by a protein or sugar that is exposed on the red cell surface. And at least one example has to be documented of an alloantibody produced by a human being. Today, the molecular basis has to be known, and a system has to be controlled by a single gene or by two or more very closely linked similar genes. And I give you examples for that. The A blood group system is defined by the ISBT, the International Society of Blood Transfusion, and there are websites that are freely available and that you can look up. So today there are 45 blood group systems published, and this slide shows a little bit the outline how this developed over the last more than 120 years. Amongst those published systems, there are 356 antigens, and some additional antigens are established but haven't found a system because the molecular basis is not known. So much is published, but this year, in 2024, there are actually two more systems already defined, which makes the total for 47 blood group systems as of today in November 2024. If you look to this timeline, there have been 21 systems in 90 years, and in the past 35-ish years, there are 26 more systems. And here on the next slide, I show you this development in a little greater detail for your consideration. First 90 years 21, the next 10 years 5, in the first decade of the century 4, in the last decade 6, and in the last 5 years 11. So in other words, this system study is not going to a limit. It actually looks like that it's becoming more interesting due to the huge opportunities that we have from a technological perspective to analyze red cell antigens, studying by molecular techniques as well as by the proteomics technologies that become available to us. So what can we expect for the future? What is on the horizon? Well, there are more than 500 distinct proteins known in the red cell membrane, and each and every one of them could become a target of an antibody and then would qualify as a blood group system. Only 47 of them are documented so far. So we may well conclude at this point there is a lot room to be explored. And we are ideally situated to cover that study. A full description defines the space for disease, pharmacology, as well as clinical studies. One example would be unexplained hemolysis that we observe in our services, and that could be based on antibodies or cellular activities to such surface antigens. And we have the opportunity to study this. This is a huge field. It's not ended. It actually could be the beginning of a lot of more clinically relevant studies, and it's at our hands. The tissue distribution of the antigens is typically very wide. It's not limited to red cells. There are actually only a few of those 47 blood group systems that are only located on red cells, and the classical example is Rh. But please keep in mind that the vast majority of those systems and antigens is widely distributed, and often the antigen density on cells other than red cells is higher than on those red cells that we are concerned with when it comes to transfusion medicine and hemolytic reactions after transfusions. 21 systems were known in the year 1989, and none of them had a molecular basis. In the next 10 years, the field exploded, and 26 systems became known with the molecular basis, except 3, Dombrok, Tsiana, and P1PK. Since about the year 2000, the molecular basis must be known for a blood group system to be accepted as such, and the last 2 remaining systems were Tsiana and P1PK, for which the basis became known in the year 2003 as the last known protein-based system, and 2011 P1PK as the last known sugar-based system. The milestones for this testing and evaluation of the genetic basis were ABO and RH in the year 1990 by Dr. Yamamoto and Hakamori and Dr. Sherif Sahar and Cadron in Seattle, the US, and Paris in France. The last protein-based was Tsiana, done in my lab back in Germany at the time, and the last sugar-based finally in 2011 in Sweden. This shows a study of routinely applied pharmacogenomics in my hospital. We use a certain platform testing about 1,200 genes, and we ask the question which of those proteins are part of the red cell membrane. And it turned out that the 12 genes shown here are exposed. At the time when we did this study, none of that were known as blood group systems, although they could be, because if somebody developed an alloantibody against the protein, it could easily be defined as a blood group system. And lo and behold, at about the same time, publications came out as defining them as blood group systems based on the fact that antibodies actually had been seen before but couldn't be associated with those genes. And once one was systematically studying the possible genes, one could associate old antigens with new genes and defining a new blood group system. So today, 4 of those 12 genes are actually defined as blood group systems, and some of them are actually new blood group systems. So this is one example of insight that one gets from such studies. Now here, quickly a comment on the molecular basis for the total of 47 defined blood group systems. 44 of them have one gene, and all 13 systems that have been defined in the past 10 years, since 2014, are encoded by only one gene. However, there are other examples where a system can be defined by 2 closely associated homologous genes, that's RH and Kaido-Rogers, and there is actually one system, MNS, where 3 genes are the molecular basis of that system. This slide shows the complete list of the 13 new blood group systems as loosely defined for those that have been detected in the last decade, since 2014. Most of these blood group systems are constituted by multipass proteins, and I will show you what that means. 2 of them are encoded by proteins that are linked to the GPI linker. 1 of them actually affects the sugar that constitutes the GPI linker. And finally, 1 encodes a transferase, an enzyme that produces a sugar on the red cell surface, just like in the case of the ABO system. Only 5 of them are actually defined by new antigens. So the vast majority has been known for the longest time as an antigen lacking the molecular basis, and now we could define the molecular basis for those. And you see that some of them are really known for a long time, all the way back to 1967. And it's good to define the molecular basis for those known antigens because it makes it much easier for you in the lab to deal with patients who actually have antibodies to such antigens. You have a total new set of tools at your hand to diagnose these patients and to adequately treat these patients, which hasn't been possible in the past, necessarily lacking molecular techniques. So this now shows the red cell membrane, and you see as an example here circled the RH protein, how it winds back and forth through the membrane with a total of 10 transmembranous segments. several loops on the outside of the red cell, on the exofacial side of the red cell, and then several protein segments intracellularly. And in fact, the vast majority of the new blood group systems constitute such multipass proteins that happen to have 2 to 36 segments in total spanning the red cell membrane. Now, amongst the blood group systems defined in the last decade, there is no protein that has only a single pass through the red cell membrane, but we do have 2 new blood group systems that are located only on the surface, so they do not span the red cell membrane, but in fact they are attached on the red cell surface through a sugar component that's called GPI, and that's the reason why these proteins are called GPI-linked proteins. There are 2 of them, CD59 and CANO. And this shows the concept of those proteins. They are attached with this sugar component to the red cell surface, and the whole protein is exposed to the surface. There are very many such components known, and one wonders that many or all of them can constitute a target to alloantibodies and would eventually become a blood group system. Now, one of those new blood group systems, called M, has a new structural feature that hasn't been known before. It's a gene that encodes a glycosyl transferase, an enzyme that affects a certain covalent binding of sugars. And in fact, and this is shown here on the next slide, this gene affects the constitution of this linker that links the GPI-linked proteins to the red cell surface. And if this sugar component is altered, then it can also be a target of an alloantibody and in fact thus become a blood group system. This was a new development a few years ago. And finally, as mentioned before, there is one new blood group system, which is a typical sugar antigen, just like ABO. Has been known for the longest time, and we finally can test it at the molecular level. It's clinically not highly significant at all, but if you see it, one might have now additional tools to analyze and exclude the relevance of this alloantibody, focusing on the true needs of the patient who has perhaps other alloantibodies masked by this one. The number of antigens per blood group system in those new blood group systems over the last decade is typically 1. There are exceptions as shown here in this slide, but for the most part they have only 1 antigen, and it's typically, which is shown on the next slide, high prevalence. That's essentially 100% for the most part. They are unlikely to be encountered in routine clinical practice. However, if you happen to have a patient with such an antibody, it obviously is very difficult to analyze even the clinical relevance of those antibodies. And with the molecular basis, the tools that you have are so much better that one can conclude that definition of a molecular blood group system is helpful for improving patient care and safety. Also keep in mind that while each one of those antibodies is rare, there's a large number of rare antibodies, and compounded, you may well be in the position to find at least one of them occasionally during your work in the blood bank. And here are the tools to analyze that in a much faster way and in a more definitive way than it used to be possible over the most decades that blood group systems have been around, and patient care was done without knowing the molecular basis. If antibodies, as I mentioned, are found, these patients are difficult to manage because many of those, not all, but many of those blood group systems have clinical consequences in transfusion medicine, as they are associated with hemolysis, for example, and often also with hemolytic disease of the fetus and newborn. They are very relevant antibodies, and it's important to distinguish those relevant antibodies from those that perhaps can be neglected. But the molecular tools allow to distinguish between them, and that's new and a big advancement over the past decade. The terminology, of course, can be very confusing. We try to keep it simple, but there is always a balance between the historical terms and a more straightforward current technology based on genes. And we try to keep this balance in the ISBT working group that defines these systems. You might also want to remember that 5 of those blood group systems are associated with diseases. So if you happen to have variants in those blood group systems, they actually can cause disease by itself, even in the absence of transfusion or pregnancy. All this information gives us the opportunity to establish large databases and to analyze these large data sets. Often we have only one antigen, as I've shown to you, but there are hundreds of single nucleotide variants in those genes, and I will give you an example in a second. And even if there's only one gene, there are hundreds of gene variants, alleles, and haplotypes. And this can actually be easily be found in databases. You don't even have to do any testing. You just go to your computer, go online, and you can analyze the data sets from anywhere in the world. This is actually very easy and cheap if you know how to use such tools that are freely available online. This is one example. Blood group 35, called CD59, has only one antigen. We analyzed the variability, and despite the fact that there is only one antigen, the genetic variability is huge. So there are more alleles, more gene variants tested and found than individual in the test group. So in other words, all of us that you are in the conference room in Muscat, Oman, including me here in Washington, D.C., we probably have only one antigen, and we share this antigen. But the number of gene variants, the number of alleles, is larger than the number of individuals in the room that you are currently in. These variants do not necessarily cause antigenic differences, but they may well have an influence on expression patterns in various tissues. And even if it doesn't affect the red cell surface, it will affect a lot of antigens on cells other than red cells, and we have the tools to analyze that. This gives a second example. You go online and you analyze the variability, in this case done for the Duffy gene. without using any pipette and any test, we simply analyzed what can be found in the 1000 Genomes Project. And as you can see, there are 2,500 unrelated individuals in that study, and we could extract, simply by computer tools, more than 900 specific variants of that gene. Again, little is known about the clinical impact of this variability, but nobody can deny that there is a possible impact, and we have the opportunity to analyze this large data set, which obviously is of huge interest in these days. Here there is now a final comment on a special current interest in Asian transfusion medicine, and that's the Asian type DEAL. So this variant shown here as RHD K409K was originally found in my lab more than 20 years ago, and it turned out eventually over the past 25 years to be of real importance in East Asia and in Southeast Asia. Not so much in South Asia or on the Arabian Peninsula, but a huge number of patients is affected, as I will show you in a second. Because this slide shows the distribution of this DEAL types and the Asian type DEAL in particular here in East Asia. The data pertains to China. And as you can see, in East Asia, the frequency of Rh negative is small, with less than 1%. Amongst those Rh negatives shown in green, there is a subpopulation shown in yellow that carries the DEAL phenotype, and almost all of this DEAL phenotype, roughly 1 million people in China, carry the Asian type DEAL phenotype. Now, why is this important? Well, it turned out that, to everybody's surprise, these DEAL patients who type as D negative by any routine serology method, because anti-Ds cannot agglutinate DEAL red cells, despite the fact that they appear perfectly normal as D negative, it turned out that they can be transfused with D positive blood. And given that you are the Asian Association of Transfusion Medicine, obviously this topic is of relevance in your field, because you may choose to start transfusing seemingly D negative people who carry the Asian type DEAL and not other DEAL variants, just the Asian type DEAL with D positive blood, making the transfusion support in East Asia, China, Korea, Japan, much easier. It almost certainly applies also to Southeast Asia. The data are a little variable in the moment, and more study needs to be done, but it's very likely that the whole of Southeast Asia has a similar distribution of Asian type DEAL as it is the case in East Asia. And that includes large countries like Indonesia, although, again, the data needs to be established, but we are in the progress of gathering such data, and then it would show how large the savings and the benefit to the patient is that we do not have transfused D negative blood to Asian type DEAL individuals who don't need the transfusion of D negative blood at all. The distribution in Europe and North America is shown here as well. Essentially, it comes down to the fact wherever you have a population with heritage from East Asia or Southeast Asia, you will find, of course, the Asian type D eel as well. And these are the key ideas to summarize. Many individuals with East Asian ancestry who type D negative in routine serology harbor a D eel phenotype, and almost all such individuals carry one distinct D eel variant, which is called Asian type D eel. And the current clinical evidence established last year strongly suggests that Asian type D eel can safely be transfused with D positive blood and do not need anti-D prophylaxis in pregnancy. This makes transfusion medicine service much easier and avoids unnecessary anti-D prophylaxis that may be scarce in a lot of regions of this world. Okay, here are some resources. When you want to do the testing, you may look into the standards for molecular testing for red cell platelet neutrophil antigens by the AABB. I'm a little bit biased because I'm the chair of the committee who sets up these standards, but I like to stress the fact, as I said at the very beginning, I have no conflict of interest. I do not receive royalties, and in fact, if you sign up, then you would receive the drafts for such standards for free when it's out for public comment. Now this just has closed and the new version will come out in January, but if you point your interest to the ABB, they will include you on the distribution for the next draft, and then you can get it free. Also feel free to check my X or Twitter account as shown here. And just the other month, a magazine report was published in Transfusion Today, the ISBT's magazine. It's also for free, where we presented an international cooperation and how that happened with Ethiopia, which is not in Asia, but it's reasonably close to the Arabian Peninsula. Now, what are the practical benefits of new blood group systems in patient care? They allow to determine and often exclude the clinical relevance of high prevalence antibodies. So if a cross-match is positive with all test and donor cells, you can determine or exclude whether that's a relevant, clinically relevant antibody and which one it is. This can eventually be done by red cell genotyping, and it often is already done with red cell genotyping. It also provides, and this is super important, a technical means to screen for rare blood donors. Once you start screening for them, you suddenly realize that they aren't that rare and that you actually happen to have antigen-negative red cell units on your shelf when you even don't need it. So the supply of compatible units to patients becomes very easy once this is established. There are many examples for that, provided that you have a high throughput test system, which typically is inexpensive. This is all well established over the last 20 years with many studies, and there are many blood centers that have that already established, and whenever a new blood group system becomes molecularly defined, then this can easily be added at really low cost. The practical benefit to know new antigens for patient care and patient safety is it enables us to investigate transfusion reactions. For example, as I mentioned at the beginning, unexplained hemolysis following transfusions. We don't know what the causes are. Here we have the tools. It's not restricted to alloantibodies. It could also be cellular reactivities. and it is a guide to study protein variants of drug transporter genes that would go into the field of pharmacogenomics with red cells. 80% or more of all cells in the human body are red cells. And of course, they are involved in the transport and distribution of drugs. And what they transport and can distribute depends on the pharmacogenetically relevant red cell proteins, as outlined in one of my previous slides. So this all combined allows us new approaches in transfusion medicine with data science using bioinformatics, biostatistics, this whole topic of big data with multifactorial analysis. We have to establish the data first, and we have to get hold and an understanding of the data before we can analyze them. But this is a huge field that we could contribute to, and it's relatively inexpensive when you have the computer resources and the knowledge. Of course, we cannot conclude this presentation or conference without mentioning artificial intelligence and the implementation of machine learning. That may be a little bit further down the road, but again, these huge data sets, once we have a hold of them and understanding, are suitable for artificial intelligence and machine learning approaches. But first, we need to generate the systematic large data sets that are required for these new approaches. As a last but one slide, there is an intricate path from genetic variant to clinical interpretation. There are very few simple answers, and most matter in this context is complex. So therefore, it's not going to be easy. Be patient, tolerate some costs, and particularly accept a pragmatic approach. Not everything can be perfect at the beginning. We have to start somewhere, and incremental improvement is better than no progress at all. Having that said, I thank Dr. Alarimi as the lead of this conference for the success to organize this Asian Association of Transfusion Medicine annual conference, supported by Dr. Al-Kain and Dr. Mujtaba Al-Lawati, who recently completed his PhD in red cell genotyping, and I was fortunate enough to participate in that PhD study in Liverpool University as an external expert. And I look forward that these individuals bring the red cell genotyping to the progress that is possible and helpful for the people on the Arabian Peninsula and in Asia and worldwide. With that, I thank very much, and I would like to conclude my presentation.